Hello, my name is Ehrin Armstrong. I'm an interventional cardiologist. I'm the director of the cardiac cath lab at the Rocky Mountain Regional VA Medical Center, as well as a professor of medicine and cardiology at the University of Colorado in Denver, Colorado. So in-stent restenosis in the femoropopliteal arteries remains a very difficult to treat clinical problem. It's associated with very high rates of target lesion failure and reocclusion, with rates often exceeding 50 or even 60% at 6 months and a year. So as a result, numerous therapies have been developed for the treatment of femoropopliteal in-stent restenosis, and these include laser atherectomy, which is FDA approved and shown to be superior to balloon angioplasty alone for the treatment of ISR. However, other studies have also shown that drug-coated balloons with paclitaxel have a significant benefit compared to balloon angioplasty for the treatment of in-stent restenosis. We hypothesize that the combination of laser atherectomy with drug-coated balloon angioplasty may provide additional incremental benefit and perhaps be the ideal treatment for femoropopliteal in-stent restenosis. The study that we designed was a retrospective study based on our own clinical experience over the course of the last 5 years. So this was a real world cohort of patients with femoropopliteal in-stent restenosis treated either with laser and drug-coated balloon angioplasty versus a control cohort of patients who we had treated with laser and balloon angioplasty prior to the availability of drug-coated balloons. There were a total of 62 patients in the laser and drug-coated balloon combined cohort and 50 in the laser and balloon angioplasty cohort. As I mentioned, this was a retrospective analysis based on 2 centers, enrolling a total of 112 patients. Because this was a real-world cohort, about a third of the patients had critical limb ischemia, and 3/4 of them had Tosaka III in-stent restenosis, meaning that they had a long in-stent occlusion. And consistent with that, the average lesion length was 247 millimeters. In our study, we looked at both the 1 and the 2 year rates of freedom from target lesion revascularization, as well as freedom from reocclusion during follow-up out to 2 years. And what we found was that the rates of restenosis when laser atherectomy was combined with drug-coated balloon angioplasty were significantly lower than with laser atherectomy alone. With regards to restenosis or target lesion revascularization, the freedom from that was only 24% at 2 years with balloon angioplasty plus laser, but was 45% when laser atherectomy was combined with drug-coated balloons. When we looked at 2 year restenosis or TLR, specifically among the Tosaka III lesions, the in-stent occlusions, which are some of the hardest to treat, we found an even more dramatic benefit of combining laser atherectomy with drug-coated balloon angioplasty, such that the freedom from restenosis or TLR was 51% for combination therapy, but only 28% when laser atherectomy was used with solely drug-coated balloon angioplasty. Based on these data, it's clear that femoropopliteal ISR remains a very difficult to treat clinical problem. Drug-coated balloons have demonstrated benefit compared to balloon angioplasty alone, but there is late catch-up with drug-coated balloons such that there may not be a significant difference in outcomes after 2 years. Laser atherectomy, as we know, has efficacy for ISR compared to balloon angioplasty alone. And these data that we presented, I think, suggest that the combination of laser atherectomy combined with drug-coated balloon angioplasty may be the best available current therapy for the treatment of femoropopliteal ISR. Yeah, I think these findings have very important implications for clinical practice. This is a real world population, so I think it reflects the types of patients who are treated on a daily basis. And I think they emphasize the value of combining these therapies and achieving the best optimal results for our patients. And I think they really speak to the fact that although we have emerging data for single therapies in the treatment of peripheral artery disease, it's really the combination of these therapies that may make an ultimate difference for our patients, and I think emphasizes the need for additional comparative effectiveness research for these treatment strategies. Well, I think the next steps for this are to expand this cohort to understand in an even larger population what some of these differences are. There are also some new drug-coated balloons available on the market that may have increased efficacy compared to some of these historical drug-coated balloons. And in addition, there are some new laser catheters, including the eccentric turbo power laser catheter, which may have additional incremental benefit by providing greater debulking. So I think understanding some of the incremental benefit of these additional combination therapies may help further drive the field forward.